Let's go back to case 5, Dara. So Dara Ras is, again, she's in the breast team and molecular. She's assistant attending, and Dara's specialty is really HER2, breast cancers related to HER2, and she's, in a way, the go-to person for all our FISH assays for HER2.
Thank you very much. I will say this talk has nothing to do with HER2, but it is an interesting case. So the next case, this is actually a recent case that came across the breast service, and it was a 30-year-old woman, no significant past medical history, and she palpated a mass in the left breast in September of 2017. So at that time, she had an ultrasound done at an outside hospital, and within the left breast, periareolar area, 7 o'clock axis, there was this complex cystic and solid lesion measuring 1.3 centimeters in greatest dimension, and at this time, a 6-month follow-up was recommended for the patient. So she then returned June the next year, and in the same area of the breast, again, she had this complex cystic and solid lesion, but now it had slightly increased in size from 1.3 centimeters to 2 centimeters. There was also a slight increase in the wall thickening. So at this point, biopsy was recommended. So a biopsy was performed at an outside hospital, and the diagnosis at the outside hospital was ductal carcinoma in situ, cribiform and micropapillary types with secretory features, intermediate nuclear grade, involving an intraductal papilloma. In the report, they mentioned that ER showed 20% nuclear staining with strong intensity, and they also commented that there was secondary cystic duct dilatation with surrounding severe chronic inflammation. So the patient then presented to a surgeon at our hospital, and her outside slides were submitted for review. So you can see at low power that there are multiple tissue cores that show this lesion right here. So on slightly higher power, you see that we have this cystic and partially solid lesion that's surrounded by this marked chronic inflammation. And on higher power, there are these fibrovascular cores surrounded by an epithelial proliferation. Some of the cells show more slightly smaller, rounder cells, and then some of their cells are slightly larger with an eosinophilic cytoplasm. And then there were also areas that showed this marked cystic change to it. So the diagnosis at our hospital was an atypical papillary lesion and marked periductal infiltrate. So the patient then went on to have an excision at our institution. So this is the excision that was performed. It was a 2.5 centimeter oriented lumpectomy consisting of tan white fibrous tissue on cut sections with 2 cystic areas spanning 5 millimeters in greatest dimension. And you can see from low power, these are 2 consecutive slices that show this cystic lesion with biopsy site changes at the periphery. So higher power of these areas, similar to what we saw in the biopsy, we have these areas with an epithelial cell proliferation. Some have these fibrovascular cores, and other areas show more solid or flat proliferation. On higher power noted throughout this lesion, we noted that the fibrovascular cores often showed this hyalinization. In addition, in areas was this solid proliferation of fairly monotonous cells that you can see here. In addition, we noted that there were 2 cell types. So towards the base of the lesion are these cells here, slightly round polygonal cells, and then towards the superficial surface, towards the inside of the cystic cavity, were cells that showed an increase in eosinophilic cytoplasm and also some flattening of the cells that we noted. There was also cystic change that was similar to what we saw in the biopsy. In addition, many of the cells showed this clear cell change, and you can see there are these well-defined borders here as well. And then there were scattered cells that showed this somewhat vacuolated cytoplasm. focally, there were these tubular structures that were lined by this somewhat cuboidal epithelium that we see here. ER was done as part of the workup, and it showed a fairly benign or non-clonal pattern of staining with a limited number of cells showing moderate to strong intensity staining, but a good majority of it did not show staining. So at this point, what was our differential? There were a few things about this lesion that were somewhat not typical. So in our differential, we have breast lesions, and then perhaps this is a skid end exal tumor. So higher in the differential on our breast lesions was, could this be an atypical papillary lesion, such as ADH involving an intraductal papilloma? Is it possible that this is a papillary DCIS? Although the solid proliferation was somewhat limited in this, as you can imagine within this cystic lesion, if the solid proliferation was larger, we would also consider in the diagnosis an encapsulated papillary carcinoma or a solid papillary carcinoma. And these are lower down on our differential, but perhaps, an ILC with a solid pattern or this quote-unquote invasive carcinoma with urothelial differentiation. And then in the skin, within the differential was this Hidradenoma. So let's go through each of these lesions, point out similarities and differences to what we have in this patient's excision. So in an atypical papillary lesion, you have focal areas of ADH that are basically involving an intraductal papilloma. And the distinction from papillary DCIS is really the size and extent of the atypical area. In contrast, papillary DCIS shows a neoplastic epithelial proliferation with papillary architecture that is confined to the ducts. You can see on higher power here this slender filiform fibrovascular stalk that shows some branching that's lined by this single cell type here. You can also focally see areas that show a cribiform architecture or maybe even a micropapillary architecture. Generally, the nuclei are either of low to intermediate nuclear grade, and with ER-IHC will show positive staining that is strong and diffuse. So as I mentioned, our lesion really was very cystic, and there were only some focal areas that showed this solid proliferation. But as you can imagine, that if there was more of this solid proliferation, an encapsulated papillary carcinoma is something that would be in your differential. These lesions generally show a thick fibrous capsule. And on higher power, you see this monomorphic population of neoplastic epithelial cells surrounding these delicate fibrovascular cores. When ER-IHC is performed, it shows strong and diffuse staining. And when myoepithelial cells staining is performed, such as P63, you'll generally see absence of staining around the fibrovascular cores, in addition to absence of staining at the periphery of the lesion. So this looks slightly different from the current biopsy that I showed you, but in your papillary lesion differential, solid papillary carcinoma is there. You have these cellular nests of neoplastic epithelial cells and these delicate, almost inconspicuous fibrovascular cores. They're usually chromogranin positive and or synaptophysin positive, and again, ER-IHC will show this positive staining that's strong and diffuse. Now this definitely looks a little dissimilar from the case that I showed, but as I mentioned, if you had more of this solid proliferation, invasive lobular carcinoma can actually present with a growth pattern typical of a solid papillary carcinoma. On higher power, however, these cells show cytology that is more typical of lobular carcinoma with areas that show these intracytoplasmic vacuoles. And this is a report of 3 cases where invasive lobular carcinoma mimicking a papillary carcinoma was identified. The lobular nature of these cases was confirmed by the absence of E-cadherin and beta-catenin membrane expression. The invasive nature was confirmed by the presence of entrapped fat cells, the absence of myoepithelial cells, and focal merging of the solid papillary areas with classic ILC at the periphery. And then this is very rare, but it has been reported in the literature, this papillary transitional cell carcinoma of the breast or invasive carcinoma of the breast with this urothelial differentiation. So in this report from 1999, you can see the picture here, they describe these hyalinized fibrovascular cores surrounded by a solid proliferation of cells with oval nuclei, and the superficial cells are flattened. So those are things that we would think about from the breast. Now, what about skin adnexal tumors? It's something that, this patient, it was a superficial lesion, periareolar. We also need to think also of adnexal tumors. So Hidradenoma is a lesion that came to mind. There are several names for this tumor, including eccrine acrospiroma, solid cystic Hidradenoma, nodular Hidradenoma, clear cell Hidradenoma, or poroid Hidradenoma. So this can actually be a lesion in the breast that can be a source of diagnostic confusion. In the breast, it's often misdiagnosed as a sclerosing papilloma on the core biopsy, and at least in this article, they said in the excision, it could be misdiagnosed as a carcinoma with this urothelial differentiation. So what is this? This is a benign skin adnexal neoplasm. It's derived from eccrine sweat glands or apocrine glands. Common sites of occurrence are scalp, face, anterior trunk, and extremities. In the breast, it's predominantly in the nipple or the subareolar region, so more superficial. And it generally presents as a single, slow-growing, well-circumscribed, solid cystic mass. Cellular composition of this lesion. You generally see these clear, pale cells containing glycogen. There are also cuboidal or columnar cells lining tubules. You can also see areas with squamoid cells, central nucleus, and eosinophilic cytoplasm. And although uncommon, you can also see some mucinous cells. In these lesions, you can see these cystic spaces that may actually be due to degeneration of the tumor cells. They can have marked vascularity, but often the stroma actually shows this hyalinization. And this is another example of a Hidradenoma, here showing much more of this solid proliferation, which is why in my differential I presented the other cases of encapsulated papillary carcinoma, perhaps this ILC with a solid growth pattern. So, as I'm sure you can imagine from the way I put this talk, the diagnosis for this patient was a nodular cystic Hidradenoma. So malignant transformation in these cases is quite uncommon, and complete excision is curative. So take-home points for this: Hidradenoma, benign skin adnexal tumor. In the breast, it occurs predominantly in the nipple or subareolar region, and it's initially misdiagnosed as an atypical papilloma of the breast. I just thought this was a good case to present because sometimes when you're signing out in subspecialty services, you see a papillary lesion, you may automatically go to that. And this actually had significant implications for the patient. This is completely benign. She'll just receive routine follow-up as she normally would, breast examinations, and she'll be fine. And that's it.
Questions for Dara?
So generally in the hydradenomas, it could actually be negative. So if you see that more solid case that I showed, it could be misinterpreted as perhaps a triple negative, carcinoma. So those are things to really, keep in mind, and it really could be a pitfall if it shows more of that solid proliferation. Our case was a little more cystic, so it wasn't something that was necessarily high in the differential, but certainly something to consider. It's a tough call, and going back, since we had this case, I will be honest, whenever I've had a papillary lesion, I have been looking very, very closely. And I will say something that's very important about these is it really shows these two cell types. You have those smaller, rounder, polygonal cells, and then you have superficially those cells with eosinophilic cytoplasm and that classic flattening. So I think that's something that's really a clue in these, that, perhaps is this really something from the breast, a papillary lesion, or can it be from the skin? I still think that these cases still need to be excised. It could be listed, as a differential and discussed with the surgeon, and, final classification on the excision.
From a margin perspective, they don't have to be, can be conservative.
Correct.
This is a benign lesion, and that's important from the breast.
Correct. Right, exactly. All Thanks.